Good afternoon or good morning, depending on your time zone. This is Lisa Dulski-Watkins with the Millbank Memorial Fund. I'd like to welcome you today to our monthly multi-state collaborative webinar. We're very excited to have Deb Hurwitz and Pano Yeracaris join us from the Care Transformation Collaborative of Rhode Island. And they will be speaking about their really cutting edge comprehensive primary care integration with behavioral health. We're really excited to hear about the work that they've been doing and the results that they're already starting to see in a short time. Just as a quick reminder, this is being recorded and the recording will be available on our website after the event is over. So if they have colleagues that would like to hear this and are unable to join us, it will be available there. And also, just as a general housekeeping rule, if you are participating by phone or you have your computer audio on, please remember to mute it if you're not actually speaking, asking questions, or participating in the conversation. If you're just listening, please turn off the ability for us to hear your audio. So with that, I'd like to get started, and it is my pleasure to introduce Deb Hurwitz, who is the Executive Director of the CTC Rhode Island. She is the Administrative and Contract Development and Strategic Planning Chief for the initiative and works very closely with the leaders and stakeholders to improve the patient-centered medical home model within the practices that are participating in Rhode Island. She also works very closely with Dr. Pano Yeracaris, who's the Chief Clinical Strategist, and they work together to support the practices. And I've had the pleasure of knowing Deb for some time, as we've had a lot of opportunity for combined work over the last decade or so now in our work together. With that, Deb, I'm going to hand it over to you, and looking forward to the presentation.
Hi, thanks, Lisa.
Deb, can I ask you one question? Would you like people to hold their questions until the end of your presentation, or are you comfortable with people asking during the time that you're speaking?
Yeah, no, I'm happy to have people ask questions along the way. That's no problem.
Okay, great. So please, everyone on the phone, use the chat function for questions that you want to make sure that we get answered in the course of the hour. And also, it sounds like Deb has graciously allowed us to interrupt freely. I'm
happy to keep it as a conversation, and we'll just use the slides as a way to guide the story, I guess. So we can go on to the next slide. The Care Transformation Collaborative of Rhode Island. Just so people know, we are the state's multi-payer patient-centered medical home transformation organization. We've been around for about 10 years now, and our mission really is with a focus on transformation of primary care in Rhode Island. We do that in the context of an integrated delivery system, and again, we're focused, as all of us are, on the quadruple aim, I guess I would say. We have a very large and active stakeholder group that's been working with us for over 10 years, initially around primary care transformation, and now as time has gone by, we're evolving into larger systems of care, and the market continues to kind of reorganize itself in ways to build on a strong primary care foundation, but to continue to try to move towards value-based care. So like many of you, it's a similar, I think, sort of story. The next slide is our goals. Again, our focus is around increasing capacity and access to the patient-centered medical homes in the quadruple aim: quality, cost, population health, and the last one being provider satisfaction. When we talk about increasing capacity, one of those is, being able to do more primary care within the setting, but also this particular project is expanding capacity to include integrated behavioral health. So that's what we're going to talk about today. So next slide. This is just kind of how we look across the state. We've had many years of slowly expanding. We have a state of about 1 million people, And our patient-centered medical homes now care for, that number has gone up. We had 650,000 Rhode Islanders receiving their care in a patient-centered medical home. It's now over 700,000. And we're doing one more expansion in July around pediatrics. So this is both adult and children program. We've had some good success in looking at total cost of care for our CTC practices and seeing that there's been a reduction in total cost of care in our patient-centered medical homes as opposed to the non-patient-centered medical homes. We've been starting to leverage our all-payer claims database to produce some of these data for us, and we've been able to use that for our IBH project, which I'm going to present to you today. Next slide. We are also doing community health teams around the state and have expanded into expert screening in certain clinical settings as well. So we've got integrated care in practices, and we also are providing through the community health teams, community health workers and behavioral health clinicians as an extension of primary care. Next slide. Okay. And this is really just an outline for, you know, the rest of the presentation, so we can go past that. Next slide. Rhode Island has ranked pretty high on mental illness and substance use problems compared to other states in the country. So we have clearly, over the last, I want to say at least 5 years, have had a focus on sort of behavioral health, both mental health and substance use, as a sort of statewide conversation, and, you know, trying to figure out how best to address this. So the good thing is that, you know, there's recognition that we have a problem that we need to solve, and it's at the legislative level, it's at the state agency level, and, you know, there's a lot of focus in the state through even our SIM grant that behavioral health, both in adult and children and families, really rose to the top of our priority list. Next slide. The Integrated Behavioral Health Project had a number of goals, and so I will kind of go through these with you and then talk about how the program worked. We wanted to establish what we call universal screening, and that includes screening all patients that come into the practice for depression, anxiety, and substance use disorder. We wanted to be able to embed a behavioral health clinician in the practice to be able to provide brief intervention and warm handoffs for patients who screen positive in any of these with these conditions, and then also to provide enhanced care coordination for patients with you know, behavioral health or comorbid conditions. Again, trying to intervene not only in the patient's care, but also on unnecessary utilization of ED visits due to those behavioral health conditions. We wanted to increase patients' care management skills and being able to manage their behavioral health needs, and then ultimately be able to reduce unnecessary costs by providing the service in primary care. So in our project that I'm going to describe right now, we had 10 practices and over 40,000 covered lives in this study. So the next slide. We were fortunate to get funding from the Rhode Island Foundation, from Tufts Health Plan, and from the state SIM model. So putting all those funding sources together enabled us to put this integrated behavioral health program together and to recruit a number of practices that worked with us over the last 3 years. We're just wrapping this up now. So it was a 3-year pilot program. Next. So we put out a call for applications, and we received initially 12. 2 practices had to drop out for various reasons, but in the end we had 2 cohorts, and we had a nice mix of federally qualified health centers and private practices. The components of the program were the following. We had an integrated behavioral health practice facilitator, we call it. It's an individual who is a clinical psychologist and whose content expertise is integrated behavioral health in primary care. And this individual was able to work with the practices on a regular basis, monthly. They would have team meetings and really implement the model. The model being, again, universal screening for depression, anxiety, and substance use, and then bringing on board an integrated behavioral health clinician who became part of the PCMH care team. A little bit different than having a compact where you can refer out, or somebody who maybe, works for another organization and they may come and sit in your practice. This is an employee of the practice. They have access to the medical record. They're part of the care team. They're part of pre-visit planning. They're available for consults, etc. So they are on site. Part of the work that they did is they did 3 PDSA cycles of improvement. And the first was to get their screening rates up to the target range. Another was around focusing in on patients who are using the ED and seeing if they could intervene on folks that had behavioral health motivators that are sending them to the ED, and then looking for comorbid conditions with chronic, behavioral health and chronic conditions. And then we brought the groups together on a quarterly basis for best practice sharing, sharing data, sharing barriers, challenges, all of that kind of thing. If we heard specific issues that were challenging the barriers, we would often bring in a content expert on that particular issue the next time around. Or if it was a system problem, we'd try to reach out to our partners, health plans and others, to try to solve some of those issues along the way. So those are the ingredients of what our model was. Next slide. We also provided practice payments. We provided $35,000 per practice over 2 years, and they received an infrastructure payment, which was based on their attributed lives. So $15,000 per 5,000 attributed lives. And then they got incentive payments for hitting the screening targets. So there was an ability to earn additional dollars for, getting your screening rates up and then hitting certain targets. Next. We had a qualitative evaluation performed, and the evaluators went out and met with the care teams in the different practices. And what we kind of heard back kind of universally was that the providers, once they got the system set up and they were actually engaged and working with a behavioral health clinician in primary care, they absolutely loved it. And in some cases, they couldn't even imagine ever practicing primary care again without having that kind of resource in their practice. So we had a really positive response from the providers. The screenings, I think, people kind of were a little bit skeptical, like, they had always been doing depression screening. That was a CTC deliverable for a long time. But when we added anxiety screener and substance use disorder, some of the folks felt like, oh, I know if people are anxious and whatnot, but it really validated to them that sometimes the patient doesn't disclose or they don't pick up on some of these things, the anxiety level, substance use disorders, unless they're really screened for. So systematic screening, there was a really good reaction to the fact that systematic screening did yield positive revelations, if you will, that their patients were struggling with some of these things. As part of the PDSA I mentioned earlier that was focused around the ED, this was not an uncommon thing where people, identified that folks were going to the ED often, and that anxiety was one of the big underlying issues there. And as they started to work with people on, one, identifying it, and two, managing, giving them techniques and ways to manage it, those ED visits dropped off, and people were coming back to primary care, maybe more often, but they would, rather have them coming to the primary care practice than going to the ED. So we have a really comprehensive report. These are just a few of the highlights, but these I think capture, sort of some of the messages I think that we felt were really important to communicate. Next. Lessons learned. Some of the things that came up that were sort of system issues that are actually, I'm excited to say, are being dealt with. We found that copays were often a barrier, particularly for the commercial folks, and that when somebody goes to primary care and they were also going to see the behavioral health clinician, they'd get hit with 2 copays, and the second copay was at a specialist level. So that became a problem kind of right away. We're pleased to say that the Office of the Health Insurance Commissioner here in Rhode Island spearheaded a parity study, and the governor signed into legislation in January the fact that behavioral health visits would not be charged at a specialty rate. They would be the same copay as primary care. What we're advocating for now is that in an integrated setting, to see, just 1 copay and not 2. So part of the issues being dealt with, but it was definitely a barrier for the commercial. Billing and coding, another challenge. All of the practices were not really fully aware of what codes they could use in primary care, how best to bill, or they would bill to the, not everybody's, they didn't feel was covering all of the codes, so they billed to the lowest common denominator, and they're underbilling or not billing at all because they didn't feel it was ethically the right thing to do. So we had issues around billing and coding. And we also, I think, one of our lessons learned here was not only to deal with the billing and coding, but to deal with it much earlier on, so make it one of the startup activities and not, partway through the implementation to say, and by the way, are you billing? Really get to it early. And having practice facilitators. So I mentioned that we had an individual who is a clinical psychologist whose area is integrated care. As we, matured and evolved in this program and started to get requests for additional support from other practices, we needed more practice facilitators trained in integrated behavioral health. And that's one of the things that we did in a pre-pilot. We actually studied the value of a practice facilitator. We were able to see that practices who engaged with a practice facilitator whose, content knowledge is in integrated care, they were much more likely, statistically significantly likely, to achieve the goals that they set out for transformational change. So the behavioral health practice facilitators are key, and that there's not enough of them, and we needed to do some training around that, train some more people up. One of the other comments that we got from our qualitative evaluation, this is in the middle, things we do differently, is that you try to give the practices a little bit of time up front to get set to do this. So we got the funding, we put out the calls for applications, we said, okay, great, we're ready to go. Everybody is 2 feet in all at once. And so they're trying to get their EHR working, they're trying to get their people hired, they're trying to train the staff, all the stuff happening at the same time. Where if we gave them a little bit of ramp up time, some of these sort of back office kinds of things, could get dealt with, and people would be more ready and less stressed when the whole thing goes live. So that's a really good lesson. And, it's just always a difficult challenge when, we get funding sources. It seems like there's never any, time or paid time to have people, get geared up, but that would be a strong recommendation. So for these things, as we mentioned, credentialing was another issue that came up to be a problem. Now, fortunately, because we were doing the pilot program, we could ask our health plans to expedite an application, but this got addressed also at a statewide level, that credentialing for behavioral health clinicians needs now to happen within 45 days, and that's actually been put into regulation. So so that was another issue that got identified and actually dealt with. And then I think going forward, what would be, most helpful as we were thinking about, going forward, it's continuing to build the workforce for integrated care, both the practice facilitators, but also more people like licensed social workers that are trained coming out of school to go into a primary care setting. So we've been fortunate to be able to work with Rhode Island College, who received some SIM funding and really geared up a program around this. And so this past year, we placed 15 social workers who were graduating from their program and needed the work experience to get their license. So we're starting to see some workforce development there. Our Office of the Health Insurance Commissioner is working on alternative payment models in primary care and is focused on also being able to do integrated behavioral health in an alternative payment model. So we are excited about that and, you know, sort of stand at the ready to try to help inform that in whatever ways that we can. And I think I mentioned the legislative action around the co-pays. You know, we would like to see some of these screenings, you know, more reimbursable across the board and also maybe treated as preventive screening so they don't trigger a co-pay. And for smaller practices, as I mentioned, this was an embedded behavioral health clinician that we tested. So the person was the practice was either big enough to have a full-time behavioral health clinician, or the minimum size would have been, you know, 2,500 attributed lives, a half-time person that could work like Monday, Wednesday, Friday. So there's always at least, you know, tomorrow there'll be somebody on board that, you know, they could plug into if they weren't able to do a warm handoff that day. So for smaller practices, our community health team was the way that we were addressing behavioral health for practices that aren't big enough. They could make a referral to the team. So that's a different story, and we can talk about that another time. But those were some of the big takeaways for us. Next slide. We'll look at some of the results. This is our universal screening results. You can see across the top, the blue is depression screening. And all of our practices had been doing depression screening for some time. So they were pretty high, you know, up at the 85, 90% rate of depression screening. But then you can see that Cohort 1, which started in Q4 of 15, you know, pretty quickly got their anxiety and substance use disorder screening rates up to the threshold. And then the other cohort started in that Q1 17. And so these practices are patient-centered medical homes. They were, you know, well established in the sense that they had teams already in place. They had been doing a lot of work together on sort of workflow. They understand that kind of that nuance and training and stuff. So we were happy to see that people kind of quickly were able to, you know, translate the work that they've been doing around quality improvement and whatnot and to get these measures up. So screening rates were accomplished. And next slide. Next slide, yeah. Okay, so this is sort of our big slide. This is the total cost of care. The data comes from the all-payer claims database. And this is where we were really excited. So the top line, the red line, is adult practices that are not patient-centered medical homes. And you can see the per member per month cost, risk adjusted, in the 800 range. The black line in the middle, that's, you know, 742 down to 690. That's our CTC practices over time. So, you know, we're significantly below the non-PCMH practices and trending down. But the other two lines, the purple and the blue, those are the practices, are patient-centered medical homes with the integrated model in place. And you can see a pretty significant decrease in the total cost of care. So the difference between and our patient-centered medical homes, you know, average of $45, let's say PMPM, and then, you know, $63, $64 PMPM compared to non-PCMH. So we are really excited about these results. We are also having another evaluation done by Brown University where they're going to use the APCD data to do the similar kind of analysis, except that they'll do a matched comparison group. So we expect to see those results in maybe another couple of quarter or two, you know, this year, but it might not be until the summertime. So the next slide, let's see what we have next. Medicaid was the big driver in here. You can see that. And then I think the next slide would show Medicare. Yep, a little bit flatter, but there. And let's see what else we got. Emergency department visits. This is, you know, you look at the purple line as an example. That was our first cohort. They were always above our CTC practices. And you can see that once they got going, they, you know, quickly decreased. And then they continued to go below the comparison groups. And inpatient, a similar kind of a pattern there as well. Workforce development, we mentioned that, and we did train 3 more people who are all, either licensed social worker, the therapist, psychologist. They were interested in being trained to be a practice facilitator. And so we developed a program with a 6-month didactic and experiential training. And they were able to actually work, once they sort of graduated from this training program, they plugged into a practice for a year to get trained up. I mentioned this other qualitative evaluation that is that we're going to be seeing soon. We are starting to partner with systems of care and ACOs. We've signed a contract with one of our pretty good size ACOs to implement integrated care for their primary care practices. And also United Healthcare, we just kicked off this morning another cohort of practices for a 1-year learning opportunity in integrated care with funding from United Health Plan. So that was really exciting. We had 9 practices there this morning with all their staff and team. We are anxious to see an alternative payment model be developed around this, maybe similar to the way that we have a nurse care manager on site. It's part of, if you meet the criteria of a PCMH practice, then you're eligible for sustainability payment that supports your care coordination functions, which in large part is paying for the nurse care manager as well as some of the other staff. And we are continuing to inform policy at the state level. OHIC, our Office of the Health Insurance Commissioner, this week just kicked off an integrated behavioral health work group, and they are focusing on the things that we had identified here: copays, credentialing, and what was the other issue? All 3 of the things that we identified. They've got them slated on their
coding and billing.
Thank you.
Coding and billing.
Thank you. I went blank. The billing and coding. So we're happy that the work that we're doing is, interesting to people. They're reading our reports and then, using some of that to help drive, the system change within the state. And, of course, we hope to be able to, disseminate our lessons learned and our learnings as we go along and continue to replicate this. I think that might be the last slide. There was some takeaways here in terms of how do you sustain this. I think we're finding that the systems of care, that's the SOC, are actually really interested in this, and because they are in value-based contracts, it makes sense to them that they need to better manage, their populations of patients that have behavioral health conditions. And so I think people are willing to make the investment knowing that it pays off. We established a ton of really great partnerships through this project, and they're listed there. We talked about the lessons learned and the evaluation. I think I kind of hit on all of that already. Next. So main takeaways, integrated behavioral health and primary care really works. It's improved access to behavioral health for a lot of patients that otherwise wouldn't qualify for the, community mental health centers. That's sort of moderate, and, depression, anxiety, and substance use disorders can be addressed through primary care setting. And so I think, in part, we're seeing, improved access, as well as the reduced costs. We think that the practice facilitation that's provided on site is key to a successful implementation and really helps with the culture change and just, making the change that's necessary. And then going forward, we're really advocating for alternative payment models, no copays for behavioral health screenings, eliminate that same day copay, and continue workforce development.
So you want the numbers on Anthony Davis on the floor versus off the floor?
So that's it.
Deb, thank you for a great presentation, and really appreciate your sharing what has been a long-term goal and project for the team in Rhode. So thank you very much. There have been a couple of questions that, thanks to Pano, who has been monitoring the chat. Just want to make sure that we just get to everything that people want to ask. And at this point, if you would like to ask additional questions, we can do that as well. So just for everyone, one question that came from one of our colleagues, Eric Muther in Philadelphia, was which particular screening mechanism you were using for the practices. And Pano, you answered that. I don't know if you want to elaborate on it at all.
Sure, Pano, are you there? Are you on mute?
Or Deb, you can answer that.
We use the PHQ-9 for depression. We use the GAD-7 for anxiety, and we use the KJADE for substance use. While we were doing this for substance use disorder, while we were doing this project, we also received a grant from the state to implement expert screening statewide. And that grant in the state required us to use the DAST and the audit. So people kind of had a choice. It wasn't so much about the tools themselves as the fact that they were doing it. And so some of the practices, because they were doing both expert, under the grant as well as this, switched from the KJADE over to the DAST and the audit, which are longer screening tools. They're, validated and all, but they're longer screening tools. So for many of the primary care practices, the KJADE is the right length. It's a, shorter number of questions. It's easy to administer, and they're right there in primary care. So it works pretty well.
Great, thank you.
Mm-hmm.
So another question that came in was specifically about the comparison group of non-PCMH practices, and the question was whether those were, given the size of your state, those were outside Rhode Island, but they were all inside Rhode Island. Is that correct?
That's correct, yeah. And that's becoming more and more of a challenge for us, because I think I mentioned early on, we're sort of getting to a point where, 3/4 of the state now are, have come through CTC or, have become patient-centered medical homes. So the comparison group, which used to be really big, is getting smaller and smaller. So we, recognize that we need to, continue to be kind of aware of that.
You're victims of your own success. Have you widespread implementation? So another question that came in was about the timeline for the analysis that you were done, specifically the qualitative analysis process, and how long it took to gather feedback from the participants.
Oh, okay. Let me think about that. That probably from start to finish might have been about 6 months. I would say, if that's the question, is how long did it take to do it? I mean, there was a little bit of an education process with the evaluators. They did a literature review. They put together sort of, sample, interview guide that they would use. That went through some review and tweaking. And then they went out into the field and they interviewed multiple people at each practice, sometimes individually and sometimes in a group, depending on how, the team felt about it. I think they interviewed in total about 45 people over that time period across 10 practices. And then, obviously they do the whole analysis, the thematic analysis, and then, write up the report.
Great, thank you.
Mm-hmm.
And then there's another question about methodology, which was or really just trying to understand what the payer mix was among the various study groups. So was that the same or controlled for? That's a specific question from Dick Shank. And then,
it wasn't controlled for, but we have looked at the data by payer, sort of after the fact. Generally the FQHCs would be a heavier Medicaid population than the private practices.
Right.
What we did see, and sorry, I lost audio for a while there that I took off, but what we did see, this is Pano, Yeracaris with CTC, what we did see was that the about 70% or so of the effect on the total cost of care differential, first point in time to last point in time, so the difference is about 70% of that was due to a decrease in cost on the Medicaid population, and then another 25+% was in Medicare. So not surprising. Some of that, is what you'd expect, although also we know that the copay barrier, at least on the commercial side, and I know it's an issue with Medicare as well, but at least on the commercial side, anecdotally, there was some reticence in some patients to take that because of the dual copay at the time of referral to IBH and all of that. But it was predominantly a Medicaid effect on the total cost of care.
Thank you. And then one other specific part of...
just one last thing around that. We expect that more academic, rigorous evaluation through the Brown School of Public Health, they will be controlling for that as one of the factors as they do, matched patient controls based on who receives services.
The one other group that Dr. Shunk was interested in knowing was whether some of the practices had more predominance of Medicare fee-for-service specifically, because as you know, he's been looking at Medicare fee-for-service and comparing that to Medicare Advantage and seeing some differences in outcomes. Do you know if
we didn't look. I looked at Medicare itself as one kind of line of business, but didn't separate out Medicare fee-for-service versus Medicare Advantage.
Okay, thank you.
I suppose I could try to do that. We can do it by health plan now. That's a functionality that we just got about a month ago, so that I can look at. But I'd have to look at. I don't know if I can do Medicare. I could probably look at Medicare by health plan and whatever. But so, Rich, if you got a small grant, you want it. I'm kidding.
Yeah, looking on my own. Yeah, okay. Fantastic though study. I really enjoyed looking at the data. It's great.
Thank you, Dick. There's another question from Eric Muther. So he's asking, in addition to the measuring the impact on the total cost of care as you did you also look at and track behavioral health outcomes as part of the project? So looking at follow-up care or rescreening after a certain number of months, the time interval.
That was done at each individual site level. We weren't able to muster up enough resources to collect all of that and aggregate it up. So the practice facilitator that went on site every month would review with the practice, their implementation, sort of, fidelity to the model, if you will, but also would talk with the practices and look at their way of capturing data on follow-up. So what we would recommend is, and the practices did implement a little bit differently, but we did recommend that if they had a positive, that they should try to do a 6-month follow-up and get the patient back. In some cases, the practices began to screen everybody every time they came in, which had pluses and minuses. They didn't need to do that, but it was like, in some cases, having a good registry that really triggered for them when they needed to follow up and bring people back in, was not easily done in the electronic medical records that they have, and they either had to set up something separate, or a simple way was we have this slogan here: we ask everybody, and so they ask everybody every time. And so, we talked about that a little bit this morning. It's not what we're recommending, but, definitely if it's a positive, I'm going to try to screen them within 6 months. If it's a negative, annual's probably fine. Although things can...
Yeah, that lack of registry function, I think, in the EHRs was a real issue for everybody. Some practices were able to create a flow sheet and then be able to extract data from the flow sheet and then be able to give it to the medical assistants before pre-visit planning as part of that process in terms of, gaps in care and other things like that. Another of the practices that mentioned that just was like, we're going to do it every time for everybody. They have a larger commercial population, and so some of them were getting bills, especially those with high deductible plans, and so they were getting a lot of complaints about that. Even if it was just $5, it was it was adding up, and so they've stopped that process of every visit, every time. But it's been a challenge, and it really is a error or a need in the functionality of the EHRs that folks identified.
Yeah. Did that answer the question? I'm just trying to remember. Was there two parts to that question?
So yeah, it was no, it was really just wondering how you were able to track sort of the clinical outcomes, essentially behavioral health outcomes.
Yes, and so like the rescreening obviously is an important one. If they're, we talked about that at the kickoff this morning, and one of the folks was talking about how they, will re-administer the screens and then, monitor the treatment and use the screen as a gauge of whether or not the treatment is having an effect.
Yeah, I guess another thing to look at, well, here I am helping you design your program, but I mean, in terms of satisfaction, that's for patients, that because they have readier access, and things may be getting identified that otherwise would have gone missed on the screening. Because nobody wants to do the screening if there's no action that can be taken. It's sort of like, great, identify a problem, but you need to have the right to address it. Right. So, this is incredibly important work. And we are part of a learning collaborative, I'd love to be able to figure out how to be able to spread this kind of, nothing created a toolkit, but I think there is, I suspect, a significant amount of interest on the part of many of our colleagues on the phone, as well as those who weren't able to join us today. So I'd like to maybe just put our heads together, you and Deb and Pano and me, to try to figure out if there's a way to really share some of the ideas and tools that you really felt were like, key to, and you've identified some of those in your presentation, but I suspect some you may find more impactful than others. So
yeah, this is Alicia, and I'd like to add to that, because I'm selfishly sitting here thinking we are working on our next learning session. Our stakeholder group, we have a behavioral health work group that's really trying to figure out how to do the education in these primary care practices here in Arkansas. So Debra, the tools you've created for training, is that or do you have someone on your team that would be willing to kind of help other markets out, either by kind of presenting for us or participating in some of the CPC in-person learning sessions? Because you guys have done great work here.
Yeah, thank you. Yeah, I think we'd be happy to share whatever we can. One of the tools that we didn't mention in this presentation it's publicly available, is the main assessment. It's called the MEHAF. But it's an integrated behavioral health assessment tool that the practice teams sit down together and they rate, the degree of integration based on these criteria. And they're pretty specific. And there's like 18 or 19 different domains. And so we have them do that at the beginning, and I think we might have even had them do it at the middle and the end, to sort of see that they're making progress and, where they wanted to make the progress, as well as, implementing the bigger model that we have here. But it was that was one really helpful tool. Because sometimes we had people who had behavioral health on site, and they said, well, we're already integrated. We have a behavioral health clinician as part of, our employ. But when they sat down to do the assessment, they're like, oh, so maybe we're not as integrated as we thought we were. So yeah, so we'd be happy. I mean, you can feel free to reach out and let me know what you're looking for. We'll try to do what we can to help you. I think, if it's a presentation or to share the tools, we're happy to do that.
Thank you.
Yeah, thank you very much.
Sure.
And actually, just along those lines, Deb and Pano, these slides are really obviously a lot very helpful for people. Are you able to share them publicly? Can I put them up on the website and send them out to the group? Or is there anything that needs to be?
No, I don't see anything that's restricted. We've been presenting them all around the state, so they've been out.
Great. So just for everyone on the phone, those slides will be up on the Millbank website under the webinars and the primary care transformation pages. And I'll also send them out to the group that was invited to this webinar.
I just wonder if my phone number is on the front. I know it has my email, I think, on the front, maybe.
Okay. We can take a look.
But you could, yeah, if you want to just put contact information there, I'm happy to.
Sure. Yep, I can modify that. That's great.
Okay, super.
All right. Are there any other questions or comments for today? This has really been a great discussion. We so appreciate your generosity, Deb and Pano.
Oh, we're happy to share it. We're excited about where we're at, and we know we have a long way to go still, but we're excited to hear back also from other people, you know, what we can take.
I would just also reflect, there's one of the things that we noticed, and that it's kind of, as we put our Rhode Island view of comprehensive primary care, which I know is, you know, we're trying to adopt some of the CMS lingo, but it's really true, is that the community health team part of it, which Deb mentioned in part of the presentation, you know, we had sites who had community health teams and who had integrated behavioral health. And in some of the, you know, that second PDSA cycle where they were looking at high ED utilizers, and one of the comments that they had sometimes was, well, we couldn't find the people, you know, and we were trying to do assessments and we couldn't find them. It was like, well, did you think about your community health team and using them for outreach? And it was kind of like, even within these same organizations, and we know that happens all the time, there were the silos that the IBH and the care team wasn't actually putting it together, that they should use their community health teams for some of these high-risk folks that they were trying to reach. So that was just a really poignant example of, you know, the further work that needs to be done. And, you know, we're really, because we have the PCMH kids part of our program too, is we really do have the vision of, you know, across the age spectrum, patient and families, as Deb talked about, as being kind of the core part of that work. And you know, right now our community health teams and our IBH have been focused on the adult population. We do hope we'll get this grant to expand it, at least the IBH portion, to PCMH kids, to the pediatric practices, and then trying to figure out in our community health team sustainability, because they were a large part, not entirely, but a good part was funded through SIM, and that SIM ends the end of June. So we're, you know, putting back to how to keep sustainability on the different pieces, but keep the pieces moving towards a more integrated, comprehensive approach. That's kind of where we're at with those areas.
Yeah, that's a great summary of kind of next steps and some of the other things that we're working on. Thanks for that, Pano.
Great. Well, thanks to both of you, and thanks to everyone on the phone. I know it's a vacation week for a lot of people, so. Yeah, but we did have a good 25 people were on the phone today, so glad to have that.
Awesome.
So thanks so much again, and the slides and the recording of this will be available on the website tomorrow. So I look forward to our next meeting, which is in a month from now, and we have the team from what was formerly the Camden Coalition, which is now the Center for Chronic. Gosh, I can't remember what. Anyway, they have a blueprint for chronic care. It's very exciting work based on Jeff Brenner's work, and some really interesting recommendations that I think will be highly applicable to people involved in the primary care transformation. So look forward to everyone next month, and thanks again.
Great, thank you.
Bye.
Take care.